I have my official question slide at the end, but I want to make this a little more informal. So if you have questions, any experiences you want to share throughout, I think that would be really helpful. This is partially informative, but I actually want to learn as well because as a gynecologist for many years, this is nobody's favorite exam at all. As a gynecologist, I will focus mainly on the female exam, but I do want to discuss anal cancer screening as well, which applies to everybody. When we're talking about anogenital cancers, this is really what we're talking about. So this is like I'm looking at a woman from the side. So you've got, the butt back here, you've got the belly up here. And so we're talking about the cervix, the vagina that's here, the vulva, which is like the outside stuff that you see. And then we're also going to talk a bit about the anus. So that's like the very opening of where you poop from. This is the muscle that keeps it inside so that you're not constantly soiling yourself. So cancer risk in the setting of Fanconi anemia. So if you look at, what's out there, the risk of vulvar cancer, which is that outside part, is increased anywhere from 500 to 3,000 times. A 100 times increased risk of cervical cancer. Now, interestingly, if you look in the literature, a lot of times it'll say increased risk of anal cancer, period. I have looked multiple times. I've talked to the people at the NIH. I have not found any real good numbers at what the risk or the relative risk of anal cancer is. So that's one of the things I want to talk about. The other thing is that the average age of diagnosis is much earlier. So in general, when we see vulvar cancer, it tends to hit women more in their 60s. On cervical cancer, you start seeing in the 50s. So we're seeing a lot of these cancers in women in their 20s, so much earlier. Now I know these numbers sound really scary, right? 500 to 3,000 times increase, 100 times increase. One thing to know is that these are, especially vulvar cancer, is a rare cancer in the general population. So, for my patients who don't have FA or other risk factors, that risk is about 2 out of 100,000 women will develop vulvar cancer. So what does this mean for FA? And as you know, all of our studies tend to be relatively small just because that's a rare diagnosis to have. So this was a study looking at just over 2,500 patients with FA. And you can see that the incidence, the number of cervix cancer cases was just over 5 out of those 2,500 patients. Vulvar vaginal cancer, there were, somewhere just over 20 cases in that 2,500 patients. This is another study that looked at more than 5,000 patients with Fanconi anemia, and you can see that cervix cancer rate is about the same, right? So you double the number of patients in this study, and the number of cervix cancers was about 12. So, double the number of patients, double the number of cancers. In this study, the number of vulvar vaginal cancers, so at 20-something, was relatively similar. So again, hard when you've got small numbers of patients, because in medicine, 1,000, 5,000 patients is actually relatively small. I know for Fanconi anemia, that's actually a really good number. So not the most common cancer, but something that we definitely worry about. And then looking at what is the contribution of stem cell transplant, right? So what you can see in blue are patients with FA who did not have a stem cell transplant versus those who did. And you can see that the risk is increased. And we do know that patients who have transplants for other reasons that are not FA also have an increased risk, probably because there is some lifelong immunosuppression associated with that. Again, this is the first time that we're seeing anal cancer kind of here, so definitely increased compared to what you'd expect in the general population. But again, just not well studied. I'm sure that there are some patients who have had a stem cell transplant who have had anal cancer, but that wasn't represented here. So one of the big questions is this HPV associated? So pretty much in the general population, almost all vulvar cancers, so 70% of vulvar cancers are associated with HPV. 95% of cervical cancers and about 60% of vaginal cancers are associated with HPV. And the question is that the case in patients with Fanconi anemia? So this is just, kind of what I show my residents when I'm teaching them about, screening for lower genital tract or cervical cancer in general. So one thing I always stress is that pretty much every adult is infected with HPV. It is any sexual contact. It does not have to be intercourse can transmit HPV. And if we were to test everybody's blood, even if they've never had a positive HPV test, we'd find it. When we do those cervical cancer screenings, we're looking for expression that's high enough that it may cause pre-cancer or cancer. We don't want to find those low levels, so we put people through way too many procedures they don't need. So pretty much everybody's infected. There's a lot of stigma associated with it. It shouldn't be. In the general population, 90% will clear that HPV infection within 2 years. They're not going to get cancer. Even those 10% who have persistent disease, some of them will get this persistent, so that's your low-grade lesions. 40% will still regress by themselves without any treatment at all, and so those patients are also not going to get cancer. And there's that much smaller population that will develop precancerous changes of the cervix, and they've got about a 30% chance that over the next 10 to 20 years of getting cervical cancer. So one of the questions that comes up is, does Fanconi anemia decrease the clearance of HPV? And when we say clearance, we really mean suppression. And that's why some people will have HPV, testing that's positive at one point in their life. We retest them later, it's negative, and then it turns up positive again, or maybe it was negative, hadn't changed their partner, and it turns up positive later. Doesn't mean their partner's cheating on them, doesn't mean they were cheating. But does FA decrease that suppression or clearance? So again, we know that stem cell transplant outside of FA does increase the risk of HPV-associated disease, so probably does decrease the risk of clearing it. There are contradictory studies showing increased or decreased HPV prevalence in patients with Fanconi anemia. So there's one study that shows that there's a decreased incidence of HPV, and then there's another where they controlled for age and for sexual history that showed that actually they had a higher risk. So again, these are all retrospective studies, hard to say, but I'm not sure that that's what's driving all of it. The other thing that we look at is when we have cancers we think maybe HPV associated, we can actually test them for HPV. So they do this very commonly in head and neck cancers. We're increasingly doing this in vulvar cancer. And to a certain degree, we're doing it in cervix cancer as well. When you look at some of the studies in patients with FA, they found that a lot of times they can't find HPV in these cancers. So then the question is, well, is there something in the variation in the FA pathway that can lead to these squamous cell cancers even if you've never been infected with HPV? The other thing is that usually in the general population we say it's not just getting the HPV, because again, most people get infected, but it's that persistence, right, that we are picking it up year after year that actually leads to cancer. In patients with FA, is it possible that you need that HPV there to start it, but that there's something deficient in the FA pathway that even if you're able to suppress or clear that HPV, that pathway that started, that cycle that starts leading to cancer continues going even if the HPV disappears. So here are just some basic science studies that have been done. And so this was looking at the FANCD2 mutation. And what they found is that if you had a lack of FANCD2, that basically you had more HPV. And so that's what this bar graph shows here. These are actually what it looks like when we get cervical biopsies. So this actually looks, very much like normal cervical stroma. So you can see you've got these nucleated cells at the bottom, and then you've got this, you lose that at the top, right? And that's what we want it to look like. And then you can see here, there's this multiple layers of these abnormal cells here. So what this study suggested is that if you have a lack of FANCD2, then actually you have more HPV. The other thing is that carcinogenesis, so not just having the HPV around, but it actually has to integrate into the normal cell and change the normal cell. It is known that an intact Fanconi anemia pathway limits HPV integration into the host DNA. So is it that the HPV can be there or not, but that you've got, when you don't have an intact FA pathway, that you've got more integration into the normal cell, and therefore have a higher risk of cancer than somebody who has an intact FA pathway. And in fact, there is a poster out there that I just saw yesterday. It's poster number 5. Interesting looking at some of these questions, and they suggested that potentially you don't even need full integration to drive that carcinogenic pathway. So I don't have a slide on that because I saw it literally last night at the poster session, but definitely look at poster number 5 because I found it really interesting and I think it does add to this literature. So then the other question is, what happens, this whole question on do you need HPV persistence to get cancer? So what they looked at is FANCD2 again, and they looked at taking away FANCD2, they looked at having HPV, and then looking at taking away the HPV. So in this first series on the left, what it shows is that without HPV, when you have this loss of the FANCD2 gene, it doesn't change anything. So that suggests that it's not, at least in this gene variant, that it's not just the Fanconi anemia pathway alone or the deficiencies in it that's causing cancer. The middle one is showing, okay, if you have persistent HPV E7, so this is the oncogenic protein, this is the HPV-created protein that causes cancer. If you have persistent HPV expression, do you get cancer, and does it change if you've got an intact or a deficient FANCD2 pathway? And what this shows is it doesn't matter. Even if the FANCD2 pathway is there and functioning fully, that persistent HPV, you still get cancer. And that's what this showed. These are exactly the same. And that's kind of what we knew from the general population. So then let's look at, okay, so you have loss of FANCD2, and then let's turn off the E7 protein. Because again, in the general population, patients who maybe had HPV at one point, suppress it or clear it, they're not going to get cancer. And what they're showing here, and I think that this really tells us what's going on, is that if you have an intact FANCD2 and then you get rid of the HPV, that actually you don't get cancer. But when you had HPV, turn it off, but the FANCD2 pathway is not intact, that you actually get cancer. So you can see that this slide here, I know it's not the best visual, but looks much more like this rather than the stratification here. So taking all of this away, HPV infection is likely to initiate the carcinogenic pathway. So this suggests that's probably not just FA alone without that infection that causes cancer. But the loss of the FA pathway allows for persistence of that carcinogenesis, so that cancer pathway it keeps going, even if the persistent HPV is not present. So even if you're able to suppress it, you're still at a higher risk of cancer. So what does this mean? Number one, vaccinate against HPV. Do not listen to RFK. It is a safe vaccine. We have hundreds of thousands of doses that have been given. I think actually, at least in Minnesota, I know a lot of you are Minnesotan or Minnesota adjacent or have had some treatment, and I think the FA community in general actually has a better vaccination rate in my experience, because I think a lot of you are aware of this and a lot of your providers have recommended. So it is available as early as age 9, and it's, vaccination age is between 9 to 12. We actually want you to be vaccinated before you start becoming sexually active. That's when it works best. Yeah.
You need to revaccinate against HPV if you had a transplant.
We don't have great data, but the recommendation is yes. So the question was, if you got vaccinated, got a stem cell transplant, do you need to revaccinate? I will say we don't have great studies. If you look at the recommendations for anybody who's had a stem cell transplant, they do recommend revaccination 6+ months afterwards. And we do know that repeat vaccination is safe. So we have studies in the general population when the 4-strand HPV vaccine was given, and then they looked at 9-strain. Giving 9-strain after 4-strain in the general population didn't make a difference, but I think one of the important things that was seen is that these individuals who got 6 doses over their lifetime didn't have any increased negative effects. Was there another? Yep.
Working 2 different types of HPV vaccination, those Gardasil, Cervarix. Which ones would you recommend for FA patients?
So the question is that there's different brands of the HPV vaccine. The 2 most common are Cervarix and then Gardasil. Currently Gardasil, the HPV-9, is the only one available in the United States. There's a lot of other formulations out there if you are not from the United States. I know a lot of countries are trying to make their own just for cost, right? Because especially now we're charging more and more to export. So I would say probably whichever vaccine you can get your hands on. So like I said, if you live in the US, right now it's only the 9-strand HPV Gardasil vaccine that's available. But if you're in a different country, they're all shown pretty much to be the same. I would say get the highest number of HPV strains that are covered. And there's no good data, so like I said, in the general population, if you got the 4-strand HPV vaccine, there was no benefit to gain the 9-strain. We don't know anything about higher risk populations, so that would include FA, that would include people who had stem cell transplants for other reasons. Solid organ transplants, totally unrelated, we actually don't know that data. So I think the biggest problem is going to be healthcare coverage, right? If you got it once, your healthcare insurance may not cover it. Again, it's safe, so if you said, you know what, we don't have data, I know I'm at high risk, I want to get that second one, it's probably safe. We don't have any good recommendations that if you, let's say, got your vaccination after your stem cell transplant, you never got one, that you need to be revaccinated.
Is it correctly understood that Cervarix covers more strains of HPV? Is that what you're saying?
Cervarix covers less. Gardasil 9 is the one that covers the most strains, and they are working on a 12-strain HPV vaccine. I don't know when that's going to be out. That was just, I talked to a rep at one point, and that's what she told me. Other questions? Yes?
Right now, is that just the 3 shots? There's no additional vaccinations on them, correct?
That's right. So right now, if you look at the general guidelines for the general population, if you're under the age of 15, it's actually a 2-dose series. For higher risk patients, the CDC still recommends 3 doses, and a lot of it is we know that 3 doses is safe. We don't have a lot of data in higher risk populations on whether 2 doses is sufficient. So we know that for the general population. So right now the CDC, for anybody included in that higher risk group, they're still recommending 3 doses.
If you're a test break.
So the question is, if you test HPV negative, do you still need it? I would recommend yes. I would even say if you never got the vaccine and you test HPV positive, it's probably still worth getting, especially just because, again, FA is a higher risk population in general. So one thing, again, it's best to get it when you're young, but if you haven't, catch-up has been shown to be effective. And technically, if you look at the FDA guidance, there is no caveat that if you tested HPV positive, you can't get it. It's basically based on age. So right now, it's FDA approved from age 9 until 45, and it doesn't say anything about what your HPV test has been in the past.
Why for the upper age limit?
So to be honest with you, in the general population, there doesn't seem to be a huge population level difference anywhere above the age of 17 to 21. Now again, when I say population level, that means taking large numbers of people. Do you change the rates of these cancers, substantially? Looking at individual risk, that's different, and that's why they approved it up to 45. I don't know why they cut it off there. I think at that point, again, we start seeing these cancers in the general population in the 50s. So by that time, I think part of the thought, and again, I don't think it's based on great data, I think it's more just based on natural history. The people who are going to get their cancers, that process is already in process. So because we start seeing in the general population, we see an uptick in cervix cancer in like the late 40s to early 50s. That's actually the middle age that we start seeing it. Above 45, who get vaccinated, that HPV's already been there doing its work. It's already starting that carcinogenic process, so you're probably not going to make as much of a difference. But again, I think that upper age limit is not based on great data. At some point, they had to pick a cutoff too. So I think it was kind of like, that makes sense, but it's not because we have studies that show, well, if I vaccinate after that, it's even less effective than 45. It's not based on that level of data. Other questions? Okay, let's talk about screening. Everybody loves this table with stirrups. So the nice thing is the Fanconi Cancer Foundation actually has a really nice guidebook. I'm sure a lot of you are familiar with this. It talks about all sorts of different cancer screenings. So again, because of the focus of my topic, we're going to focus on gynecologic cancer screening. So there's actually 2 different places in the book that they address this, and they give 2 different ages. Very confusing. So vulvar vaginal, so taking a look at least at the outside. They say start anywhere between the ages of 13 to 16. So in one place in the book it says 13, you can see this chart that I blew up here. It actually said 16, and menarche is just when you start your periods. Now I know that can be a difficult thing depending on what your hormones are doing with FA. So basically it's just taking a look on the outside. The reason that they're recommending as early as age 13 is because the earliest cancer has been diagnosed at age 14. And then basically biopsying any suspicious lesions. I tend to put vinegar on. So vinegar is a really interesting solution. I don't know who thought to put it in the genital tract to begin with, and just thought, hey, let's try it, but it works really well. What it does is it actually interacts with abnormal cells, and they turn this whiter color. So some really subtle lesions, if I look, I'm like, yeah, this looks normal. I'll put vinegar on it. Just hold it on for a minute, that's it. Same thing that you buy at the grocery store. And then I look to see if there's any more subtle lesions, because there are times that when I just look, everything looks okay, and these smaller lesions will start showing up. And so the recommendation is to biopsy anything that looks suspicious. There are some reports in people with FA, and especially those who have had a stem cell transplant, that some of these lesions can actually look very different than you would expect in the general population. I very specifically had a patient with FA who she had, I swear it was a skin tag, just normal little outpouching of the skin, and she was really anxious about it. I was like, fine, we can biopsy it, and it turned out to be precancerous. So it was a good lesson to me. I really didn't think I'd do tons of these examples. It's nothing, you're worried, let's do it. So anything that looks suspicious, and again, her communication was, I don't remember seeing this before, and so I took her word for it and I biopsied it. Cervical cancer screening, the recommendation is to examine from the age of 16 or menarche with a comprehensive examination. So that is getting a PAP and HPV co-test after the initiation of sexual activity or by the age of 16 to 18. I want to point out this recommendation for PAP and HPV co-test, because remember that data, we don't know if the HPV sticks around. So increasingly in the general population, we're moving toward primary HPV testing, where you get a swab for HPV. If the HPV is negative, you don't do anything further. For high-risk populations, that includes FA, that includes solid organ transplants, there's a whole lot of people who fit into that. Co-testing is still recommended. So again, if you're seeing a gynecologist who might not be as familiar with the FA population, as we move more to primary HPV testing, I would ask for them to do the co-test, because I don't know that HPV testing alone is going to be sufficient. And then biopsy of any suspicious lesions. And so if we get a biopsy and it shows low-grade changes, so low-grade in gynecology means there's HPV changes but no precancerous changes. The recommendation is surveillance every 4 to 6 months, and that's in contrast to the average risk population where we examine them every year. I think the big thing is that shared decision-making is essential. So we are starting this earlier than we start in the general population. So cervical cancer screening in the general population starts between the ages of 21 to 25, depending on which guidelines you're looking at. And we're recommending this in the teenage years. A lot of people aren't even sexually active at that point. A lot of you have been through a lot by the time you get to your teenage years and are seeing me. And I have a lot of patients who, the trauma of that exam is much greater. I meant to bring some different speculums for you to see, and then most of the time I'm flying by the seat of my pants and left clinic and forgot. But there are different sizes, there are different shaped speculums. As a cancer doctor, I actually have teeny tiny speculums. We call them pediatric speculums. They're about this long. I have two sizes. The smallest one's actually this wide, and then I've got one that's like this wide. I use them actually a lot for my patients who have had radiation for different gynecologic cancers, but I use them in some of my FA patients. As you know, a lot of you are smaller, and all the anatomy is smaller, so using a ginormous speculum, not a good idea. And you'll see in a lot of my patient notes, I make notes to myself. Once I see somebody, I will have underlines like, this is the speculum I use, they tolerated it. The other thing is I have a lot of patients who go under anesthesia for their exams. Like, just cannot tolerate it. And this is FA patients and non-FA. I want to just point out, this is not just, all of you in this room. I've got a lot of different patients who can't tolerate exams for multiple different reasons. Because a lot of you undergo other procedures, endoscopies and things like that, I actually will coordinate. You guys will get, scope from above. I'll come in at the end, do the below exam under anesthesia. So those are all things that can be done. I think it's working with your provider and finding something that works for you. And, if it really is uncomfortable, telling them that. Letting them know, asking, is there a different size or shape speculum that you can use? Is there any way you can make this more comfortable? And then the other thing that, Blue and I were just talking about is that, in medicine, we're very disease focused, right? So you show up on my schedule, it says FA screening. And I'm like focused on, okay, are there any vulvar lesions, are there any cervix lesions? A lot of you are only seeing the person to do your FA gyne cancer screenings, right? You're not seeing another general gynecologist. And I will say as a cancer provider, I don't always do the normal testing like sexually transmitted infection testing. And I will admit that I sometimes forget to ask, but that is something that absolutely, if you want to be tested, you should ask. Honestly, if I'm doing my job right, I should be asking if you need it. Nothing to do with FA, but if we're down there anyway, get all the swabs. Any questions about that? Or comments, or things that have worked or not worked? So here's another question, what about anal cancer screening? So like I said, if you look in the FA literature, they do often mention increased risk of anal cancer. Anal cancer is another squamous cell carcinoma. We do not have any guidelines in the FCF guidebook for anal cancer screening. What is anal cancer screening? So again, just looking at, the rectum is where your poop lives and it all comes out. The anus is just this very lower part. It's where the muscle is so that you can hold your poop in. And so this is the part that we want to, test. I want to be clear that a colonoscopy actually does not look at the anus, okay? So the colonoscopy, what they're looking at is up here. By the time they get their scope in, they're past that. So the way that we do anal cancer screening is actually just this little Q-tip. So we call it like an anal pap, an HPV test. We don't use the big brush, we don't use a speculum for the screening. Basically, you just put this little swab in, twirl it around for about 20 seconds, send it into the pap vial. If that's normal, you don't have to do anything more. If it's abnormal, then they do what's called high-resolution anoscopy. It's not showing you great pictures, I don't want to traumatize people, but basically they put like a little, something that opens the anus up and take a really good look with a light. They can biopsy anything that looks abnormal. The other thing that they can do is treat precancerous lesions, so hopefully you don't get cancer. So again, that is nowhere in the guidelines. I have started talking to my patients, who are coming in to see me. I offer it to them just like I offer it to any of my patients who have had precancer of the vulva or the cervix or the vagina. And it's really shared decision making at this point. I did talk to the people who are doing the NIH study, and they are starting to get anal swabs as well. So hopefully in the future, we will have a real, what is the risk? And we will have real guidelines. But right now I am offering this. I think the hard part is that this high resolution anoscopy step is not offered anywhere. So there is a lack of providers who can do it, and so that's one of the problems depending on where you live. If you do this PAP and it's abnormal, if you can't get to this step, it's not helpful. So that might be a limiting factor. So I think one of the things that's come up, and I've talked with ISIS and others about that, is that, we know that gynecologic and anogenital cancer risk is increased with FA. It's not as increased as head and neck. And what that means in medicine with, a rare disease to begin with is it's really hard to study. So I showed you the screening recommendations. It tells me what age to start. It tells me how often to do it. What's really hard is when you have an abnormal, so I think this came up at the cancer session, one of the advocates went and said, I had a diagnosis of atypical cells. What does that mean? And obviously it caused a lot of anxiety. And I was sitting there thinking, yeah, it causes me a lot of anxiety too, because honestly, when I have a patient who's got what we call an ascus pap test, which is basically that atypical, general population, we just say come back in a year. And I'm kind of stuck between, well, I don't want you to get cancer because I missed it, and at the same time, I don't want to put you through more procedures than you need. So we need better data. We need to know what is happening when we have those mildly abnormal changes. Does it turn into anything or not? What can I watch? What do I need to biopsy right away? So the NIH is doing a study. This is the QR code if you want to go to their website, where they do bring people to the NIH and they're screening them. They're getting swabs from top to bottom, and hopefully we'll get more data that way. My understanding is they haven't done much with the anogenital swabs yet. And we talked a bit about the data commons as well. So if your institution's involved in that, that's another way that hopefully we'll start getting this data from around the world and start understanding what's happening. So there's my question slide. That's my email. You can always feel free to email me. I will never give you medical advice, but I can at least give you kind of the recommendations. So you can feel free to contact me. I'll bring that back up in case anyone wants the QR code. Yeah.
So for anal cancer screening, would you ask your GI doctor or your GYN?
Really good question. So we are at the University of Minnesota, and partially I've got a partner in colorectal who's really interested in anal cancer prevention. His primary focus is men who have sex with men, but in any high-risk population. So we're collaborating and we're starting to do it in all our GYN patients who are at higher risk, meaning that they had a history of pre-cancer. So our GYNs are doing it, some primary cares will do it, some GIs will do it, so it will be very provider specific. I'll be honest with you, the first good anal cancer screening guidelines just came out in February 2024. So there's a lot of providers who don't even know how to do it. So that's going to be another problem. Hopefully we're going to increase that, again, because they came out. The biggest problem is they came out from an organization that a lot of primary care providers don't refer to. So the United States Preventive Services Task Force, USPSTF, are the guidelines. They've got guidelines for like breast cancer screening and cervical cancer screening and all sorts of things. They were supposed to come out with anal cancer screening guidelines after the International Anal Intraepithelial Neoplasia Society came out with them. It's a mouthful. Unfortunately, with our new administration, that got taken. And so the problem is a lot of primary care providers will refer to USPSTF because that's like a one-stop shopping. Like, go there, get all of your general screening recommendations for prevention. Other questions, discussion. Everybody excited about the grant? Okay, well, thank you.